Please start.
Okay, thank you. So, a very good afternoon to all the participants of the winter school, the esteemed speaker, and everyone present here. The topic of this session is ultrasonography of urogenital system, and it is my privilege to introduce you before you a very skilled and knowledgeable scientist working in this field, Dr. Abhishek Chandra Saxena, who is working as a senior scientist in the division of surgery at ICR IVRI Izzatnagar. Dr. Saxena, he has done his BVSc in AH from GB Pant University of Agriculture and Technology, Pantnagar, and he has done his master's and PhD degree in veterinary surgery from IVRI Izzatnagar. And he has been a part of several institute as well as external funded projects as a PI as well as a co-PI. And he has to his credit publications in international as well as national journals, and he's also credited with several awards in his field. So, with this brief introduction, I would like to welcome and invite the speaker of the day, Dr. Abhishek Chandra Saxena. Dr. Saxena, please.
Thank you, ma'am. A very good afternoon to all the participants of this course. Am I clearly audible?
Yes, you are.
Okay, thank you. So, for the next 60 minutes or so, we are going to discuss about the sonographic examination of the urogenital system, especially in the small animals. Now, the urogenital system is one body system in the small animals which can be thoroughly examined with the help of ultrasonography because of the nature of the organs that we have to examine. Except a few components like ureter, most of the other parts of the urogenital system can be thoroughly examined, and there are certain conditions which are very amenable to be examined through sonography but not through other commonly available diagnostic techniques. So this technique also has an advantage of evaluating structure as well as function. Another good thing with the ultrasonography is that there is no radiation hazard, as we observe in the cases of radiography where there is a lot of radiation hazard involved. The radiation hazard is also there with the CT. Therefore, this technique is very innocuous in nature. It causes minimal discomfort to the patient because there is no invasive procedure involved. So all in all, this is a very versatile technique with which we can examine most of the body systems and especially the urogenital system. So we will be starting with the organs and we'll take organs one by one. We'll see how the organ can be examined, what are the approaches, what are the normal orientation in which the organ should be examined, and also what are the different affections that can be examined for that particular organ. So we'll start off with the most commonly and easily examined organ, which is the urinary bladder. Now, the ultrasonography has an ability to distinguish soft tissues from the fluid. It is a very unique ability that this technique has, and therefore this organ, urinary bladder, becomes a very good organ to be examined with the help of sonography because it is soft tissue, means the walls of the bladder are soft tissue and there's a urine filled inside the bladder. Therefore, it provides a very good contrast to the entire structure, and also it acts as an echo window to examine the deeper structures. So when we examine the urinary bladder, the transducer in the male animals are placed parapreputially. In the females, they are placed in the caudal abdomen, and the transducer are oriented in such a way that the cranial aspect of the bladder should be displayed towards the left of the screen, whereas the caudal aspect of the trigon aspect of the bladder should be located towards the right of the screen. This is the normal orientation. And since we scan the animal in the dorsal recumbency by placing the transducer on the ventral aspect, the ventral wall of the bladder goes on the top and the dorsal wall goes at the bottom. So normally the transducers cannot nicely resolve the near echoes, and therefore the near wall or the ventral wall of the bladder is sometimes not that clearly visible. And sometimes you can also find the side lobe artifact that you are seeing. This haziness is actually the side lobe artifact here. However, the dorsal wall, which is the far wall of the bladder, in this image is clearly examined, can be clearly evaluated. So this is the sagittal section of the urinary bladder. When we take the sagittal section, we also angulate the transducer to cut several sagittal sections onto the right and onto the left so that we can see the entire bladder in different sections in long axis view. Now, keeping the transducer at the same location, when we rotate the transducer by 90 degrees, then we can get the transverse section of the urinary bladder. In the transverse section of the urinary bladder, just dorsal to the dorsal wall of the urinary bladder, this crescent shaped structure is the cross section of the descending colon. So this colon is filled with feces that does not allow the sound waves to pass through it, and therefore there's a shadow, and only the near wall of the colon is visible. It appears as an elliptical object. Otherwise, this is the transverse section of the urinary bladder, and this is the far wall of the urinary bladder. In the transverse section of the urinary bladder, the right side of the bladder should be displayed towards the left of the screen, and the left side of the urinary bladder should be displayed towards the right of the screen. These are the internationally accepted conventional or the conventions for the orientation of the urinary bladder in the animals. So when we examine the urinary bladder, this is just to show you the normal topography of the prostate in the male animals. This is the catheter passing through the prostatic part of the urethra into the urinary bladder. This is the trigon region of the bladder where the ureter might be opening on the dorsal aspect of the wall. And this is the apex of the bladder, which is the cranial aspect of the bladder. Now, coming to the affections that can be observed in the bladder, we can see sedimentous concretions. Now, these sedimentous concretions are not well formed or large concretions. In fact, they are very fine concretions. They may get embedded into the clots. Sometimes there will be inflammatory exudate also in the urine, and it forms a mat-like structure over the wall of the dependent wall of the urinary bladder. And since there are concretions in this mat that will not allow the sound waves to pass through them, therefore we can encounter this acoustic shadowing. So there will be hyperechoic sedimentous concretion followed by a very sharp, clearly demarcated distal acoustic shadow. These are sedimentous concretions. You can also see these concretions here, sedimentous concretions. But at the same time, the concretions can be large also. For example, in this case, there is a large concretion. Also, you can see that the bladder here, the bladder is not having clean urine. The urine here is also turbid. There's a lot of sediments floating in the urine, making it turbid. When you see the concretion, only the near surface of the concretion will be visible, because the concretions will again not allow the sound waves to pass through it, and therefore the entire concretion will not be visible. In fact, it might appear like as if it is floating in the urine. Only the near wall is visible, and there are sharp shadows emanating from the concretion that have masked the dorsal wall of the urinary bladder. So this is a typical appearance of a large cystolith which is present in the urinary bladder. Again, you can see in these images, these are large cystolith causing sharp shadowing that has masked the dorsal wall of the urinary bladder. Different shapes of the uroliths can be found in the bladder. So these are large, well-formed cystoliths that can be encountered, and they will always be accompanied by distal acoustic shadowing. Sometimes there might be less mineralized cystolith, or there might be a small cystolith that is present with the inflammatory exudate. So the shadows will not be that sharp, and also the image of the concretion will not be that distinct. It will not be having sharp edges, as you can see in this image. This is a less mineralized small cystolith present in the bladder. But there is a distal acoustic shadowing that is indicative that the mineralization has started actually. Another common condition encountered in the small animals is the cystitis. So one of the indicators of cystitis is the increased thickness of the urinary bladder wall. So you can see here, this is the urinary bladder, which is almost flaccid. The animal has probably urinated, but still you can make out that the bladder wall is remarkably thickened, and the mucosal edges, they are not uniform. They are undulating, thickened mucosal margins in the wall of the urinary bladder. Again, you can see in this case, and most of the animals affected with the cystitis, this thickening is more evident on the cranial aspect of the bladder as compared to the caudal aspect. This is the transverse section of the urinary bladder, and again in the transverse section of the urinary bladder, we can see that there is a thickening on the urinary bladder wall. Also, it can be seen that the urine is not clean, it is turbid, probably because of the inflammatory exudates and other sediments floating in the urine. Again, this is a case of cystitis, but in this case, as can be seen here, that the bladder wall thickness has not increased. We say that the bladder wall thickness is increased if the bladder wall thickness is more than about 4 to 5 millimeters. Actually, the bladder wall thickness will depend upon the distension of the bladder. If the bladder is void and flaccid, the bladder wall thickness may go up to 4 or 5 millimeters also. But in a partially distended or a distended bladder, normally the wall thickness remains less than 2.5 millimeters. So anything more than that can be considered. But in this case, as you can see, that the bladder wall thickness is not increased, but the urine is remarkably turbid. You can see there are a lot of sediments floating in the urine. So this is again a case of cystitis. Another type of cystitis that we encounter in the small patient and small animals is known as emphysematous cystitis. You can see the bladder wall here. Since in emphysematous cystitis, the gas-producing bacteria is causing infection, there will be accumulation of the gases in the bladder wall, and the bladder wall will become echogenic. As you can see, this is white echogenic bladder wall, and since there will be gases in the bladder wall, there will be shadows coming from this wall. Gases cast shadow. So these shadows you can see here, they are all emanating from the echogenic bladder wall, patchy echogenic bladder wall. So this is a case of emphysematous cystitis. Sometimes the gas accumulation is so much that only the near wall of the bladder is visible in entire lumen, and the far wall of the bladder, they become invisible because of the shadows coming from the near wall of the bladder. This is again a case of emphysematous cystitis. And see the near wall, hyperechoic near wall causing a lot of reverberation and shadowing, and that has masked the entire bladder wall lumen. The far wall is also echogenic, but since the shadows of the near wall, they are masking the rest of the things, therefore they are not that conspicuously visible, but still it can be seen that the entire wall of the urinary bladder is echogenic. This is a case of emphysematous cystitis. Then we can also find polypoid cystitis, where we can find these polypoid-like structures. Sometimes they imitate the clots, blood clots in the urine, but you can agitate the bladder, or you can ask the animal to walk for animal owner to take the animal for a short walk and examine again. If these were clots, they will get displaced from their location. But if they were polyps, and again, if you have color flow with you, you can also switch on the color flow Doppler to see the blood flow into these polyps. Then another condition that can be easily identified is the urethral obstruction. So the object that is causing the obstruction is mostly located near the os penis in the male dogs, and therefore it is difficult to imagine. The cats also, male cats also, there is a urethral obstruction produced by the urethral plugs, but these urethral plugs are located deep inside the pelvis and cannot be usually seen. What can be usually seen is the distension of the urethra. So you can see this is the trigone region of the, or the caudalmost aspect of the urinary bladder, and this is the prostate, and this is the prostatic part of the urethra. You can see the prostatic part of the urethra is remarkably dilated. This is again a case, you can see this is the caudalmost aspect of the urinary bladder, and this is the prostate, and this is the urethra, prostatic part of the urethra passing through the bilobe prostate, and it is remarkably distended. So these all are indicative of a distal urethral obstruction. We can go for a radiograph to see what is causing the obstruction, or at what location or what level it is located. Then this is a case of cystitis and cystorexis. So this animal also suffered from rupture of the bladder, though the rent in the bladder cannot be usually seen with the help of ultrasonography to see whether it is, and you can also observe that there's some amount of fluid which is present just in the vicinity of the urinary bladder. So this fluid can be ascitic fluid, it can be the urine that has leaked out from the urinary bladder. So we can differentiate whether there is any cystorexis or not simply by catheterizing the animal and then passing some sterile saline into the urinary bladder. So that if the bladder is ruptured, the urinary bladder will get distended only for a transitional amount of time, say about few seconds, and then all this fluid that has been infused inside the urinary bladder will leak out to the periphery of the bladder, and it will get accumulated here. So we can see this is the, and then you also tap this urine and send it for examination to see whether there's an ammoniacal smell, or you can also examine for the pH. So all these things can be done to differentiate cystorexis from simple ascites. Then we can also locate urinary bladder tumor in the bladder, and most of the times they are transitional cell carcinomas, though we cannot identify the type of tumor only with the help of sonography. We need biopsy, we need cytology of the urine to confirm the presence and type of tumor in the urinary bladder wall. But definitely we can switch on the color flow mapping to see the blood flow into the tumor. Sometimes the clots, they also hang like this from the wall of the bladder and imitate a tumor. One way to differentiate them is just to agitate the bladder or ask the animal owner to take the animal for a short walk. So if this is a clot, it should dissolve or it may disperse, and or it will change its location or its appearance or its shape. So if this is happening, probably it was a clot, otherwise it can be a tumor. Again, for confirmation, we need biopsy or cytology. So this is again a transfer section of the urinary bladder. The entire bladder is filled with the transitional cell carcinoma. We performed the ultrasound guided biopsy from this case and we confirmed it as transitional cell carcinoma. You can see the tumorous tissue lying on the dorsal wall of the urinary bladder. This is again to confirm the blood flow into the tumor. We have switched on the color flow and we can see the blood flow into the tumorous tissue in the bladder. Also, we can see that the urine is very cellular. It is very turbid because of the exfoliation from the tumor. And this urine can be sent for biopsy and cytology. This will also sometimes help us in identifying the type of tumor. Then again, in cats also, urethral obstruction is very common. And this is the distal end of the urinary bladder. And you can see the distended urethra passing through the pelvis. Though when it reaches the pelvis, we cannot exactly see the urethra, but we can see the distended urethra. Can be traced up to the pelvis, where we cannot see the rest of the course of the parent urethra, but we can still identify that the urethra is dilated, and therefore there might be a distal urethral obstruction. More commonly, it is seen in the male cats. Another organ that is examined just close to the urinary bladder is the prostate in the male animals. Prostate is located at the caudal aspect of the bladder, and the urethra immediately after emanating from the trigone of the urinary bladder passes through the prostate. It is known as the prostatic part of the urethra. In the dogs, the prostate is bilobed. One lobe is located on the left side and another on the right side, and in the sagittal section, both the lobes can be seen separately. To see the prostate, we have to angle our transducer caudally from the urinary bladder, keeping it slightly caudal to the normal location that we use for seeing the urinary bladder, and then we also angulate it caudally. So that brings us the sagittal section of the urinary bladder. Then we can angulate this transducer to the right to the left to see both the lobes in the sagittal section. We can take the measurements in the sagittal section, the length and the depth. Then we keep the transducer at the same location and rotate it by 90 degrees. So when we rotate it by 90 degrees, we can see the cross section of the prostate, in which we can see both the lobes separately. So this is the left lobe and this is the right lobe, and in the center will be the cross section of the urethra. And the shadow, this black area that you are seeing, is actually the edge shadows that are produced by the edges of the urethra. So this area becomes shadowed. This is the normal appearance of the transverse section of the prostate. So you can see there's a long axis of the prostate. This is the transverse section of the prostate. You can see we have measured the long axis length and the depth. In the cross section also we measure the width and the depth, and all these four measurements are used to calculate the prostatic volume. And with the help of prostatic density that has been determined in the cases of dogs, we can also calculate the prostatic mass. So this will help us in identifying the benign prostatic hypertrophy from a normal prostate. This is the case of benign prostatic hypertrophy. The prostate is enlarged. The size of the prostate varies as per the body weight and also as per the age. And there are reference ranges for the size of the prostate with respect to the body weight and age. And when we measure these parameters in a dog, we compare it with the reference range established for that particular age and body weight, and then we can say whether the prostate is actually enlarged or not. So this is a small prostatic cyst in the prostatic parenchyma. The cyst can be of two types. One of the cysts can be located within the parenchyma of the prostate, and another cyst, it develops in the paraprostatic tissue within the prostatic capsule. So these paraprostatic cysts are more common in dogs. The parenchymatous cyst may also be seen in cases of dogs. And the cyst will be clearly having thin wall and very anechoic contents inside it. So this is the parenchymatous cyst in the prostatic parenchyma. This is the case of prostatitis, where we can see there's accumulation of fluid within the prostatic parenchyma. The prostatic parenchyma is very heterogeneous in appearance. Though simply by seeing the ultrasound images, we cannot declare it as prostatitis. This might also be a case of prostatic neoplasia. And therefore, to confirm whether it is actually inflammatory or neoplastic, we should go for a biopsy. We can go for an ultrasound guided biopsy to confirm the presence of a neoplastic lesion or not. Similarly, this is a case of we have performed this examination FNAC under ultrasound guidance, and we found that there was no involvement of any neoplastic cells. So we diagnosed them as prostatitis. Again, you can see these are prostatic abscesses. Sometimes they are very large sometimes, and a lot of fluid pus we have drained under ultrasound guidance in many dogs. Then this is the case of prostatic neoplasia. So sometimes the prostatic neoplasia is very aggressive, in which the prostatic parenchyma undergoes liquefactive necrosis, leading to the formation of small fluid-filled cavities. They may imitate as a prostatic cyst, but when we perform the ultrasound-guided biopsy and perform the cytology, we found that the tissue was neoplastic, and that it can be identified as prostatic neoplasia. Again, a case of prostatic neoplasia, you can see the appearance, very heterogeneous appearance of the prostatic parenchyma. Another condition that we encounter in male dogs is the perineal hernia. In most of the cases, the contents are usually the urinary bladder and the prostate. So if we place the transducer at the pelvic diaphragm after shaving the hairs from there, we can also image them to confirm the presence of these organs. So this is the urinary bladder and the prostate. The urinary bladder has retroflexed inside the pelvic diaphragm, and we can see the urinary bladder and the prostate as the hernial contents in the case of perineal hernia in a dog. Coming to the females, uterus is the most, I can say, the affections of the uterus are very common in female dogs, and we have to identify different conditions and differentiate them from physiological affections that we encounter in the dogs. So the uterus is sometimes very difficult to image if the animal is nulliparous, it has never given birth, and if the animal is in anestrus, again the uterus is very small, very uncharacteristic. Sometimes it is difficult to identify in an animal, especially if the animal is not properly prepared and there are a lot of bowel gases. So to image the uterus, we again have to first image the bladder, and this bladder acts as an echo window to see the uterus. The uterus is located just dorsal to the urinary bladder. So if you see, this is the urinary bladder, the sagittal section of the urinary bladder, and we can see the uterine body at the level of just cranial to the trigon region of the urinary bladder. Now this animal was it is a non-gravity uterus, and it has never given birth also. So we have used a very high frequency transducer, 5 to 10 megahertz transducer, and we are examining at 10 megahertz and at a very small depth of 4.5 centimeter. Therefore, we could locate a part of the uterus. Otherwise, rest of the uterus is actually not visible in this image. So sometimes it is difficult to locate a normal uterus. If the uterus is not visible, most of the times it is normal also. However, if the uterus is enlarged because of any physiological or pathological reason, it is readily visible to us. So you can see this is the uterus in a dog, in a bitch, which was suffering from open cervix pyometra. Most of the pus has drained out. A small amount of pus is still remaining in some pockets. And you can see the course of the uterus just dorsal to the urinary bladder. So this is the urinary bladder over here. This is the ventral wall of the urinary bladder. This is the dorsal wall of the urinary bladder. And dorsal to the urinary bladder, we can locate the uterus. This is again a non-gravity uterus, very uncharacteristic, can be missed in any organs. Though since we are examining with a high frequency and we are using tissue harmonic imaging and we are scanning at a short depth, so we can still see a part of the uterus just beneath the bladder. In this case of again open cervix pyometra, pus has drained out but still remaining in very small quantities in the uterus. but sometimes the cervix is not open. All the pus is accumulating in the urinary bladder. This is the transverse section. This is the longitudinal section. So what happens when the uterus is enlarged? It needs to occupy space within the abdomen, so it becomes tortuous. So when the uterus becomes tortuous and the beam is straight, it cuts several sections of the same uterine horn, which appear as several separated partitions within the same horns. Where actually there's no actual partition. This is simply the bend of the uterus, which has been sectioned through a straight beam. And we can also see the pus inside the uterine horns. Again, closed cervix pyometra. Then we can also see cases of cystic endometrial hyperplasia. In the case of cystic endometrial hyperplasia, it might be accompanied with pus in the uterus, or we can call it as cystic endometrial hyperplasia pyometra complex. You can see these small cystic. This is the actually cross section of the uterus, and this is the wall of the uterus. And in the wall of the uterus, you can see these small cystic structures within the endometrium. So this is case of cystic endometrial hyperplasia with pyometra. In some cases, only cystic endometrial hyperplasia might be present, and there might be no pyometra. In many cases, the cystic endometrial hyperplasia precedes the pyometra, and pyometra will develop later on. So all these combinations may be present: simple cystic endometrial hyperplasia or cystic endometrial hyperplasia with pyometra. You can also see the hyperplasia here with the cystic structures within the uterine endometrium. So this is again a case of cystic endometrial hyperplasia with pyometra. So you see the uterus is filled with pus. So this is a case of stump pyometra. The animal had underwent ovary hysterectomy, but the owner reported to us that it had undergone ovary hysterectomy, but still there is some pus coming through the vagina. And when we examined, we found that the stump was enlarged. It was having some fluid accumulation within the pus accumulation, mostly within the stump. So this was a case of stump pyometra, you can say infection of the stump. Again, this is a case of uterine tumor within the uterus. You can see this is the urinary bladder, and dorsal to the urinary bladder is the uterus. So we have also used the power Doppler here to see the very feeble and slow blood flow that is still present within the tumor wall. This again tumor in the urinary in the uterus. So this is the transverse section of the tumor, and this is the longitudinal section of the uterus showing the tumor. Coming to the ovaries, ovaries are a bit difficult to image if the animal is in any stress, and because of their location also. The landmark to identify ovary is the ipsilateral kidney. So to locate a ovary, you first have to locate the ipsilateral kidney, as we can see here. So this is the kidney on the left side. We first image the kidney, and then we go to the caudal pole of the kidney. The ovaries are mostly located caudolaterally to the ipsilateral kidney. So this is the kidney, and this is the ovary, which is located caudolaterally to this particular kidney. Same is also there on the right side. So first we identify the kidney, go to the caudal pole, and then angulate our transversal laterally to see the ovaries. If the animal is not properly prepared, if there is a lot of bowel gases, it will be difficult to identify the ovaries because of the extensive bowel interference. So as you can see here, this is the kidney here, and just caudal, this is the caudal aspect of the kidney, and caudolateral aspect of the kidney we can locate the ovary. The canine kidney also has some bursa, and bursa is fatty tissue, so it also provides contrast to the ovaries, but otherwise they are difficult to image. And most of the times the anistus ovary is slightly elliptical in shape without any cystic or fluid filled structures inside it. Again, you can see the left kidney and the left ovary here, elliptical left ovary with the animal in anistus. But if the ovary is having any enlargement because of the presence of cystic structures, or because of the presence of corpus luteum, or because of the presence of follicles, developing follicles near the proestrus and estrus, the ovaries become easily and readily visible. Like we can identify the right ovary here, which was the animal was also having pyometra. This ovary was having a luteal cyst inside it. that might probably be the reason of pyometra in this animal. Again, you can see this is the left ovary, presence of a very large cystic structures in the ovary, and then there is a presence of some smaller sister structures within the ovary also. So there are criteria to identify the cystic structures, and sometimes it's difficult to identify or differentiate a luteal cyst from a follicular cyst, but anything more than 12 to 15 millimeters is considered as a cyst. It also depends upon the stage in which the animal is. If the animal is in pro-estrus or in estrus stages, it is difficult to say it has a cyst. But if the animal is past estrus and after 1 month or so, we can find these type of large structures. Mostly they are cystic. Then this is an ovarian remnant syndrome. The animal had underwent ovariohysterectomy, but it was still showing signs of estrus. When we perform the examination, we could locate the ovarian remnant. So these are the images of, you can see this is the left kidney, and again the left ovarian remnant. This is again a ovarian remnant here. So this is ovarian remnant syndrome. Then ovarian tumor, the entire ovary will be enlarged, very heterogeneous in appearance. There will be presence of very large fluid-filled structures. This might be because of the liquefactive necrosis of the ovarian parenchyma, also because sometimes they also have some cystic structures inside it. So the entire appearance of the ovary will be changed. We can always go for a ultrasound guided fine needle aspiration cytology to confirm the presence of tumorous tissue, but this type of appearance is normally indicative of, this is also known as moth-eaten appearance. This moth-eaten appearance of the ovary is also indicative of ovarian tumor. Coming to the kidneys, kidneys are very easily imaged, and it is one of the organs in the body which can be thoroughly investigated with the help of ultrasonography. And if you see here, the left kidney is located slightly caudally as compared to the right kidney. And also the left kidney is slightly more mobile as compared to the right kidney. And depending upon the distension of the stomach, the left kidney can be located cranially, caudally, or cranially inside the costal arch also. And to image the kidneys, there are several planes in which the kidneys can be imaged. So this is known as the sagittal plane, where we place the transducer parallel to the long axis of the kidney, and we try to see the kidney through a paramedial plane. So this will give us the sagittal sections of the kidney. Keeping the transducer at the same location, if we rotate it by 90 degrees, we can get the cross-sectional planes, and by angulating the transducer cranially to caudally, we can get different sections, cross sections from cranial aspect to the caudal aspect. When we take the transducer to the dorsal aspect of the kidney, or the towards the dorsal aspect of the kidney, we can get the coronal or the dorsal section of the kidney. And in this case, the appearance of the kidney will be slightly different. We'll see both the images now. So this is the sagittal section of a kidney, which is obtained through this paramedial plane. So when we see this plane, the kidney will appear like this. This is the kidney has two different regions. The outermost or the peripheral region is the cortex, and the central region is the medulla. The cortex is hyperechoic as compared to the medulla, because medulla contains most of the tubules, and the tubules contain urine, and therefore the medulla becomes hypoechoic. In the medulla, we can also find these white bands. These white bands are renal diverticuli, which divide the medulla into several components actually. And along these diverticuli, the renal vessels, they move from medulla towards the cortex. This is the sagittal section. When we go for the coronal section of the kidney, so this is the coronal section of the kidney when we see the kidney from the dorsal aspect, and this is how the kidney will appear. There will only be cortex on one side. The other side of the cortex will not be there. And you can see the clear view of the renal diverticuli. These are renal diverticuli through which the interlobar vessels emanating, which originate from the renal artery, they go towards the cortex, towards the corticomedullary junction. This is where there will be renal pelvis. The renal pelvis is a very small structure normally having a diameter of around 1 to 1.5 millimeters, and therefore it is not that clearly visible in most of the normal animals. When it is distended because of any reason, it becomes visible. So we'll see this. This is the transverse section of the kidney. By rotating the transducer in the sagittal plane, we can see the transverse section of the kidney. So this is the renal pelvis, and this is the transverse section. This is the cortex, and this is the medulla. So this is the transverse section of the kidney. So this is the normal kidney in the dog. In the normal dog, the renal cortex is hypoechoic to the spleen. So this is the spleen, which is the most lateral structure on the on the left lateral abdominal wall, and we can use this spleen as a window to see the kidneys also. So here in this view, we can see the spleen and the left kidney in the same view, and we can also see that the renal cortex is hypoechoic to the spleen, which is normal. Also, this animal is suffering from ascites. This is all peritoneal fluid. So this is the right kidney. This is the cranial pole of the right kidney. This is the caudal pole of the right kidney. And this is the caudate lobe of the caudate process of the caudate lobe of the liver. And this concavity that you are seeing is the renal fossa that lodges the cranial aspect of the right kidney. This is a small lesion which was an incidental finding in this animal. This animal is also suffering from ascites. This was a small cavitary lesion seen in the liver, which was an incidental finding. This is just to show you the topography of the right kidney. So this is the blood flow. You can see that this is the renal artery. Renal artery, it branches into several interlobar arteries. These interlobar arteries travel along the renal diverticuli and reach to the corticomedullary junction here. And these vessels at the end are the arcuate arteries, terminal arcuate arteries. So this is the normal blood flow pattern that you will find in a canine kidney. So this is a case of acute kidney injury, nephritis because of any reason. And can see that the renal cortex has become hyperechoic to the spleen here. However, the corticomedullary differentiation is still present. This is the cortex and this is the medulla. Cortex can be differentiated from the medulla easily. There's a proper corticomedullary differentiation, but there's an increase in the echogenicity and the granular echotexture of the parenchyma of the renal cortex. So this is a case of acute kidney injury. So only on the basis of sonography, we cannot declare it as an acute kidney injury. The International Renal Interest Society has laid down several criteria to identify acute kidney injury, and this is one of the parameters that we have to evaluate in those criteria. There are several others. On the basis of those parameters, we can identify whether it is an acute kidney injury or not. So again, you can see in this case, this is the medulla, this is the cortex. The cortex has become hyperechoic, and it is hyperechoic to the spleen. It is again a case of acute kidney injury, or we can call it as nephritis. Again, this is the liver here. This is the right kidney. The right kidney has become hyperechoic to the liver. Normally, in a normal animal, this liver is either isoechoic or slightly hyperechoic to the renal cortex. But here in this case, the renal cortex has become hyperechoic to the liver, which is again indicator of nephritis. In this kidney, it is difficult to differentiate cortex from medulla. There's the similar echogenicity of the renal cortex and the renal medulla. The renal corticomedullary differentiation is absent. So it is an end-stage chronic kidney disease, nephrotic kidney. Again, in this animal also, it is difficult to make out the margins of the kidney, and also it is difficult to differentiate cortex from the medulla. The corticomedullary differentiation is gone. This is the end-stage chronic kidney disease. Again, this is a case of renal dysplasia. There's no corticomedullary differentiation. Again, this is a case of renal dysplasia, leading and ultimately ending into chronic kidney disease. And there's a loss of corticomedullary differentiation in this kidney also. Then pyelonephritis. Pyelonephritis. In the pyelonephritis, there will be a dilation of the renal pelvis, as you can see in these cases, but there will be no dilation of the ureter. So when most of the animals, the pyelonephritis is characterized by the dilated or enlarged renal pelvis without any dilation of the ureter. However, if the dilation of the renal pelvis is because of the ureteral obstruction, the renal pelvis will be dilated together with the ureter, which is cranial to the obstruction. So in this case, only renal pelvis is dilated. So we can infer that probably this animal is suffering from pyelonephritis. To confirmation, we have to go for other tests. Ultrasound findings are not absolute. We have to correlate the ultrasound findings with other clinical findings to arrive at a conclusive diagnosis. So we have to interpret our findings in the light of other findings. Again, this is a case of pelvic dilation. As you can see, this is the renal pelvis, and the renal pelvis is remarkably dilated in this animal. Again, this is the case of dilation of the renal pelvis. You can see the dilated renal pelvis, and together with the dilation of the ureter. So this animal was suffering from ureteral obstruction, which has caused the dilation of the ureter together with the dilation of the renal pelvis. And when left untreated for a sufficiently long period, this may convert into hydronephrosis. You can see this is the hydronephrotic kidney, which is having lot of urine within the medulla. The entire parenchyma is pushed peripherally, and the ureter can also be seen distended. The case of ureteral obstruction leading to the dilation of the ureter as well as the left kidney. Again, this is the sagittal section of the kidney, and these are the parts of the renal diverticuli that are visible. Otherwise, the rest of the kidney is filled with the urine. In this case of hydronephrosis, this is the sagittal section and this is the transverse section. Then renal concretion and renal calcification is another important finding that we can see through sonography. In this case, we can see there's a renal calcification in the corticomedullary junction, which is casting sharp shadow. These are the shadows that are coming from this calcification. Also, we can find sometimes very large concretions within the kidney. So this is a very large concretion. As we have seen in the urinary bladder, only the near surface of the concretion will be visible to us. The rest of it will be masked by the shadow that will originate from the near surface, and it will also mask the cortex. You can see the large concretions within this is the kidney. This is a large concretion here. So this nephrolithiasis, again a very large nephrolith within the kidney, in the right kidney. Then renal neoplasia is also sometimes observed encountered in the small animals. This is a sagittal section of the kidney, and we can see a large neoplastic growth within the kidney. Sometimes the shape of the kidney will be so disturbed, it will be difficult to be identified. So we have to rule out. If we cannot see a kidney on one side and we find some large distorted mass having moth-eaten appearance and undefined edges, heterogeneous parenchyma, it is again indicative of renal neoplasia. Again, for confirmation, we have to go for ultrasound guided biopsy and cytology. So sometimes in some animals, there is a distinct medullary rim, which is a white line surrounding the entire medulla at the corticomedullary junction. So in those cold countries where the ethylene glycol is used as an antifreeze, this type of lesion is very important because most of the time it is associated with the ethylene glycol toxicity. But sometimes, since in our countries we don't use ethylene glycol as antifreeze, therefore this type of medullary rim is not considered very clinically significant. However, it has been associated with some renal calcification, renal calcinosis. So if the animal is suffering from this medullary rim, not showing any clinical sign, we should warn the owner to be more vigilant with the animal, and with the onset of any sign, we may have to go for the examination. Again, we have to go for the estimation of the calcium in such animals because this animal is prone for having nephrocalcinosis. But in many animals, in normal animals also, we can find the medullary rim. Coming to the testicles are easy to locate because if they are descended into the scrotum, the transducer can be directly placed over the testicle. To examine the testicle, we need a high frequency transducer, and we examine at a very small depth. The testicles are characterized by the presence of a mediastinum testis. So this mediastinum testis is used to identify the testicle. Most of the times when the testicles are retained, this is the thing that can be used to confirm the presence of a retained testicle within the abdomen. So these are all retained testicles that we have examined in the cryptorchid animals. These retained testicles can be normal as we have seen in these animals, but sometimes they also become tumorous. For example, in this animal, the testicle has become tumorous, and we had to go for the excision of this retained testicle. Again, both the testicles were retained in this animal, and both the left testicle and right testicles were removed surgically and sent for histopathology. Another important area in which the sonography can be used in animals is pregnancy diagnosis, and especially in small animals like bitches, pregnancy diagnosis can be done at a very early stage of, say, around 15 days, sometimes even lesser than that. But normally we don't declare the pregnancy till the 20 days of gestation, at which we can declare the animal as pregnant or non-pregnant. In the early stages of the, or you can say for the first month of the pregnancy, the gestational sac is not very large, and the fetal structure within the gestational sac is not very well defined. So the gestational sac diameter can be used to predict the gestational age and the expected date of delivery in these animals. However, when the animal goes beyond 30 days of gestation, there's a remarkable growth in the fetus also, and the fetus enlarges. So the gestational sac also enlarges, and the parts of the fetus, they also become evident. Like we can see the heartbeat at a gestational age of around 30 to 35 days at the earliest. And then we can also make out the head of the fetus and the body of the fetus. So body diameter and the head diameter can also be estimated or evaluated to confirm the gestational age and to find the estimated date of pregnancy. We have to declare the animal as pregnant. Then when we have declared the animal as pregnant, we have to tell. Sometimes owner asks, what is the number of fetuses in my animal? So if the animal is in early stages of pregnancy and the gestational sacs can be individually seen and separated from each other, we can tell the number of fetuses. But most of the times when the pregnancy has gone beyond 30 to 35 days or 40 days, it is difficult to tell the number of fetuses because of the extensive overlapping of the fetal structures over one another. And therefore, we don't declare the number of fetuses with the sonography and such. We only give an idea of the number of fetuses. Then we take different measurements. We identify the gestational age and also find out the gestational expected date of delivery. And also at the same time, you also calculate the fetal heart rate to see whether the fetus is having normal heart rate or it is having tachycardia or bradycardia, or if the animal, if the fetus is in distress or not. So all these things can be seen with the help of conventional beam mode and the Doppler sonography. So in this case, you can see a very early 20-day gestational sac, and when the fetus has enlarged, this is the gestation at around 35 to 39 days. We can see the gestational sac. We can see the fetal head here. We have also estimated the gestational age by measuring the gestational sac diameter, and it has also given us the estimated date of delivery. So this is a large fetus in which most of the parts are identifiable. So these are the ribs on both the sides. This is the diaphragmatic line, and this here is the vertebral column here. And we have measured the lateral diameter of the body, which is also known as the body diameter, to estimate the gestational age. This is the head diameter. Head diameter is also known as the biparietal diameter. We measure the distance between the end of one parietal bone to the other parietal bone. This white line that we are seeing here is the parietal suture. So this is the biparietal diameter that is used for the estimation of gestational age. Again, the biparietal diameter and the parietal suture here for the estimation of, we have measured the head diameter or biparietal diameter. They are the same thing, and the gestational has been calculated at around 48 days. Again, we can use the M mode sonography to calculate the fetal heart rate. So for this, we switch over to the M mode. There will be an M mode line on the B mode image, and we place this line with the help of tracker ball directly over the heart of the fetus. And when we place it over the heart of the fetus, in the left ventricle, we can see the areas of systole and areas of diastole. So we can calculate the time between two consecutive systoles, and on the basis of which we can calculate the heart rate. But if we have Doppler with us, we can use the spectral Doppler. We have positioned the spectral Doppler in the heart at the level of, say, around, it is near the mitral valve in the fetal heart, and therefore we are seeing the biphasic flow of the mitral valve, and we can calculate the time required from one flow to the other flow in the spectral Doppler. So we have given the machine time. The machine has calculated as the heart rate at 225 beats per minute. We can also see the dead and macerated fetuses where the parts are not that clearly visible, but the two structures that are still identified in most of the macerated fetus is the head of the fetus and sometimes the spine of the. So in this case, we have seen the head of the fetus. Here we can see the spine of the dead fetus. Since there is no fluid around the fetus, it is difficult to see the fetus entire structure. And since the fetus has degenerated, the parts are not clearly visible, but still we can make out the head and the spine in the fetus. So with this, we are finished with the presentation. I'll now take some questions if there are any. Thank you. Hello. Hello, am I audible? Hello. Ma'am, your voice is not that clear. Ma'am, the voice is not clear.
Hello, hello.
Yeah. Am I audible?
So I just wanted to better now.
Actually, the voice is breaking and not getting the question that is being asked. So I can see some questions in the text box. Someone has asked, is there any side effect of sonography on the fetus? So as such, the ultrasonography does not has any severe biological effects on the body. The most, at most, it produces deep heat inside the body. Therefore, it is also sometimes used as a physiotherapy therapeutic modality. In the gestational, in the cases of pregnancy diagnosis, the only effect that it can produce is that it can heat up the fetal liquor. But otherwise, there are no other biological effects or detrimental effects of the ultrasound on the fetuses. Somebody else is also having some questions.
Yeah, they have asked, could you please show once how to diagnose prostate tissue, normal prostate borders?
Okay, I'll just share my screen again.
The explanation was indeed remarkable from your side. Everyone is
Thank you, ma'am.
Yes.
I'll again try to explain the things.
Yeah.
So when we examine the prostate, we examine the prostate for certain features. For example, we look for the size of the prostate, whether it is enlarged or not. Then we look for the parenchymatous texture, ecotexture. Normally, the prostate is very, can say, homogeneous in ecotexture. The ecogenicity is slightly higher than that of spleen. So if you see the relative ecogenicity of the abdomen, prostate is most hyperechoic, followed by the spleen, followed by the liver. Liver might be isoechoic to or slightly hyperechoic to the renal cortex, and then renal cortex is hyperechoic to the medulla. So this is a normal relationship between the ecogenicity. So when we examine the prostate, we look for the size of the prostate, we see for the appearance of the prostatic parenchyma. To evaluate the size of the prostate, we measure the dimensions in the sagittal section. We measure the length, and then we measure the depth of the prostate. Again, in the transverse section, we measure the width and the depth of the prostate, and there is a formula with which we can calculate the volume of the prostate using these four measurements. And we have also determined the density of the prostate. So by multiplying the volume of the prostate with the density of the prostate, we can calculate the prostatic mass also. So there is a reference range of the prostatic volume and prostatic mass depending upon the body weight and the age of the animal. So we calculate, then we compare the calculated prostatic volume and mass with the reference range to see whether there is a prostatic enlargement or not. So this is how we identify the prostatic enlargement. Also, sometimes because of this enlargement might be because of the benign prostatic hypertrophy. This might be because of the prostatic neoplasia also. Then, for example, in this case, this is the benign prostatic hyperplasia we have measured, and we have found that the length and the width of the prostate was higher than the reference range that has been established for a dog of this age and the body weight. So this was a Labrador Retriever, maybe weighing around 25 to 30 kilograms. So for that body weight and age, this was a larger dimensions. We can determine, and there are no changes in the prostatic parenchyma. So when there are no changes in the prostatic parenchyma, it is heterogeneous, it is homogeneous in appearance, and it is enlarged. It is mostly indicative of benign prostatic hypertrophy. Sometimes in the cases of benign prostatic hypertrophy, we can also find cystic structures, paraprostatic cystic structures in the benign prostatic hypertrophy. The thing is, we have to ensure whether this enlargement is because only of prostatic hypertrophy and not because of neoplasia, we have to go for ultrasound guided biopsy. So for example, in this case, there is a cystic structures within the parenchyma of the prostate. This is the sagittal section of the prostate, and there's a small cystic structure which is clearly demarcated, and the contents are very anechoic. There's a very small cyst. Sometimes you also find, and you see in this parenchyma, this prostate, it is very heterogeneous in appearance. We call it as moth-eaten appearance, as if some moth has eaten away the prostatic parenchyma. Therefore, at some regions it will be hyperechoic, at other it will be hypoechoic, at other it will be anechoic, because of the presence of the inflammatory exudates. But sometimes the same appearance is also seen with the prostatic neoplastic lesions also, and therefore we have to go for ultrasound guided biopsy to differentiate them. Again, you can see the prostatitis, accumulation of fluid which is very turbid. Maybe it might be inflammatory exudate. Then again, you can see the small prostatic abscesses in the case of prostatitis. Again, these are ill-defined lesions. The wall is not clearly demarcated. If you see this image, the wall is clearly demarcated. This indicative of a cyst. Whereas in these images, the wall of the cystic structures are not very clearly defined. Mostly they might be inflammatory exudate within the prostatic parenchyma.
Okay,
and then
Dr.
again, this is the case of neoplasia. So neoplasia of any parenchymatous organ, be it prostate, be it spleen, be it liver, or be it kidney, if it is an aggressive tumor, it always leads to liquefactive necrosis of the parenchyma of the parenchymatous organ. This leads to the formation of these large cystic structures within the parenchyma filled with fluid. The same lesion can also be seen in the aggressive lesions of the liver and spleen, and sometimes in kidney also. So, but again, confirmation requires biopsy. So if there is any specific question regarding some particular aspect, I can throw some light on that.
Yeah, there is. Yeah. No. The next question is: what is the line of treatment of bladder filled with hyperechoic clumps in dogs?
Hyperechoic clumps treatment.
Yeah.
See, if there is anything in the bladder, it might be a concretion, it might be inflammatory exudate. So first we have to go for the urinalysis. We have to go for the urine cytology. We should check the urine pH. We should see what are the cells that we are finding in the urine, and accordingly we have to go for the treatment. Okay. If there is simple, sometimes there might be blood in the urine because of the trauma. So we have to go for the urine examination, and after the thorough urine examination, we can go for the proper treatment.
Yeah.